Good morning. This is Dr. McDaniel. I'm a board-certified obstetrician gynecologist in New York City, and I'm bringing to you all things health-related for women. Good morning again. This is Dr. McDaniel, and I keep procrastinating on doing this presentation. I've had so many things going on that I said, okay, I'll finally just do it on the train. And then I procrastinated on that, so I'm like, okay, I'm going to do this presentation, or at least start it off so I can get the momentum going as I'm walking up to the medical office. So, hence the background. I'm in Manhattan, and I just left Penn Station, so I'm on my way over to Chelsea for the medical office. We moved in January, so we're not on 35th anymore. I'm on 26th Street. Same cross street though, still 7th Avenue. So let's see, when we left off, I had discussed the indications for hysterectomy, and I had discussed the pros and cons of the procedure, and then I said, okay, I'm going to discuss the different types of hysterectomy, because I found in the office oftentimes when I ask the patient how was the procedure done, she doesn't know, so that I have to describe it. So when you think about the uterus is sitting in the pelvis, and we can get to the pelvis either through the belly or we can get to the pelvis through the vagina. So those are the two ways we will remove the uterus. It's either abdominal or it's pelvic. It's either abdominal or it's vaginal. And then the ways we can get into the abdomen is either just a big open cut or a small open cut that's with scalpel by human hands. So we call that exploratory laparotomy. Or we can get through to it with a camera, which is a laparoscopy. And laparoscopy can be done either a laparoscopy or a camera with human hands, or a laparoscopy camera with a robot. So we can either do a robotic laparoscopic abdominal hysterectomy or just a laparoscopic abdominal hysterectomy. Now, if we're removing the uterus vaginally, then the way we're going to remove it vaginally is either with just straight vaginal removal, and that's just human hands, a surgeon, gynecologist sitting there removing it, or we can get some help. And we can either get help with a laparoscopy, so that's going to be a laparoscopic assisted vaginal hysterectomy, or we can get help with the robot, so that's a robotic assisted vaginal hysterectomy. So those are pretty much the different ways we can remove the uterus. And then you may ask, why would we have so many different ways to remove the uterus? What's the point? Well, there's recovery time. So if we remove the uterus with an exploratory laparotomy just on the abdominal wall, then she's going to require more healing time because it's a larger incision. So when I used to do the hysterectomies abdominally, or any abdominal surgery really, I used to try to make sure it was as small a cut as possible, because obviously the smaller the cut, the faster the healing time, less downtime, less pain and everything. So I used to take my two hands, put them together, and the width of my two hands would be the largest incision I would make, regardless. And usually I would try to take just one hand, and the width of one hand would be the width of the incision for that exploratory laparotomy. Now, the main reason why you would kind of be forced to do an abdominal hysterectomy would be if the uterus were just entirely too large to try to chop up and remove piecemeal through the laparoscope, through the camera, or if this lady's had a lot of several previous surgeries, there can be a lot of scar tissue. So it can be very, very difficult sometimes to place the camera, to get into the abdomen, to remove all of that scar tissue in order to see. So in that case, then you would just say, I'm going to do an abdominal, just open so I can really break through all of the scar tissue and the bands, adhesive bands. So that would be another indication for an open. Those are pretty much the main two reasons for doing an abdominal. Otherwise, switch hands here. Otherwise, there really wouldn't be a reason to do an abdominal hysterectomy. The main route would be laparoscopic. Then the question would be, would you just do laparoscopic, abdominal laparoscopic, with or without the robot, or would you do a vaginal hysterectomy? So the advantage to the vaginal hysterectomy seems obvious to me, but I'm going to state the obvious. The advantage to the abdominal or vaginal hysterectomy is that there isn't an abdominal incision, so the healing time is the fastest if you're just going vaginally. The main indication, or I guess the main allowance to allow you to do an abdominal hysterectomy will be if the patient has had, if the lady has had previous vaginal deliveries, so her pelvic muscles, the trampoline and pelvic muscles that hold everything up, if it's loosey. It's only going to be loosey if she's had vaginal deliveries. So you have to have a lot of give, because you have to be able to pull the uterus down, literally, into the upper portion of the vagina minimally, and then you can break up the bands or the ligaments that are holding the uterus up, get more descent. If you don't have any give on that pelvic floor, you're not going to be able to do that vaginal hysterectomy. Additionally, the uterus has to be small enough to pull through the vaginal canal. So in general, we used to say the uterus had to be 10 to 12 centimeters or less. So it had to be the size of an orange or less. Now in the past, in my peak surgical days, I used to be able to do a vaginal hysterectomy if the uterus were maybe, I think the largest I did was around 16 centimeters. And that would mean the size of a cantaloupe. But that was through slicing and dicing and cutting it up and pulling it down as I went along. And then needless to say, seems needless to say to me, but I do have to say the obvious, can't be a question of cancer, because you can't slice and dice and cut up cancerous uterus like that. And you also have to remove lymph nodes and everything. So if the uterus is small and you think there's cancer, you can actually do the vaginal delivery of it, so vaginal hysterectomy, but at the same time, then you have to go in with the laparoscope and do the lymph node removals to look for spread. And that's predominantly done by an oncologist, cancer specialist, not just a standard general gynecologist. And let's see. Those are going to be the main reasons why you do vaginal versus abdominal. Now, doing the laparoscope, of course, that just minimizes the abdominal wound, so it increases or speeds up the healing time, recovery time. And I almost forgot, if you do the laparoscopic, then there's less hospital time. There's less time as an inpatient, because pretty much if you do it with a camera, robotic or just laparoscopic, then the patient only needs to stay in the hospital that same day or overnight. I mean, the way things are going now, though, if you do an abdominal with an abdominal wound, they pretty much are only staying about 2 nights regardless. So it's not a huge difference as far as the hospital time goes, but it can be a huge difference as far as how she feels, pain, and recovery. Let's see. So I think that's everything. Why you would use a robot versus just doing laparoscopically is just because it's often easier to manipulate inside the abdominal pelvic cavity when you have a robot versus using long instruments yourself. That's also the manipulation inside the pelvis is a little bit easier if you're skilled with the robot versus just being skilled with the laparoscopic instruments. And when you do the procedures laparoscopically, everything is like a mirror. So when I first learned how to do laparoscopic surgery, I mean, I was pretty quick, so it didn't take me long, but maybe the first 5 to 7 surgeries, it was a little bit difficult. I had to really concentrate because everything is backwards. So when you put your instrument to your right, it's actually to the patient's left. When you put your instrument to your left, it's to the patient's right. So it's like a mirror image. So you have to learn how to mentally go for where you're going, and then just the depth perception is off, because when you're reaching for things, they look further or closer together than they actually are. So I hope that's helpful information on the different ways to do hysterectomies, why you would do different hysterectomies, different routes, and finally getting this out. And I hope it's not too much stress watching the presentation, because I don't have a gimbal, so I know it's the video is kind of jumping around, but I just want to finally keep my word and get this video out, and then I'm going to work on getting a few more videos out so there aren't such huge gaps right now. It's just a lot going on. So it's funny to me how empty it is here in Manhattan today. Yesterday it was a lot more people. Yesterday was Monday. Today's Tuesday. There's fewer people, which is good. I like it as the fewer people. I think a chunk of people are still working from home a few days a week. So probably Mondays. I feel like Mondays and Thursdays are busier days. I don't work on Fridays anyway, so I'm never out on Fridays, not on the train and in Manhattan and everything. But hope everyone has a great rest of your day. And please check out the YouTube channel. This is Facebook. I always put this first on Facebook, then it goes immediately to YouTube, and from there it goes to all the podcasts. Now the podcasts are they used to be a year behind, but since I've been so slow getting the ones out on Facebook and YouTube, the podcasts are no longer 12 months behind. I feel like they're about 3 or 4 months behind, which isn't good. But check out the podcasts. We're on all the usual platforms, Spotify, Apple, Google, whole kit and caboodle. Have a great rest of your day. Thanks for joining me. Please leave comments, thumbs up, likes, follow, subscribe, the usual, and have a great rest of your day. Bye!